suffice it to say, about 60% of men and 50% of women will experience at least one trauma in their lives, and about 8% of the population will develop PTSD at some point in their lives. This leaves about 8 million adults a year with PTSD. That's not counting children. The most common trauma for women is sexual assault or child sexual abuse, and 1/3 of women will experience a sexual assault in their lifetime, which is truly a staggering figure. There's also quite a bit of male sexual abuse and the sexual abuse of young boys. The statistics on that aren't as clear because it's a highly underreported crime. These are the military statistics, but on average in the recent wars, about 12% of veterans from the recent wars developed PTSD. From the Vietnam War, about 15% were diagnosed with PTSD at the time of the most recent study, and it's estimated that as many as 30% of Vietnam vets had PTSD at some time in their lifetime. There's also a giant problem, as I'm sure you all know, with sexual assault and sexual harassment of men and women in the military, and there's PTSD related to that as well. So here we have the just basic PTSD definitions and diagnostic criteria. PTSD develops in some, but not all, people who have lived through or witnessed a shocking or scary event that is or perceived to be life-threatening. Not everyone that experiences trauma will develop PTSD. Symptoms generally develop 4 to 6 weeks following the traumatic event, but they can develop or maybe not become obvious for years afterwards. There are 4 diagnostic criteria. Some people list 3. Some people don't include the last one, but I listed them all just so you had as much information as possible. To be diagnosed with PTSD, the symptoms must last for more than 1 month, and an adult patient must have all of the following: at least one re-experiencing symptoms. Those are like flashbacks, and we're going to discuss these diagnostic criteria in more detail in the following slide. At least 1 avoidance symptoms, at least 2 arousal and reactivity symptoms, and at least 2 cognition or mood symptoms. Re-experiencing symptoms can include flashbacks, nightmares, bad dreams, or frightening thoughts that seem unrelated to what's happening in real time. Avoidance symptoms can include, basically avoiding places, things, events that remind one of the traumatic effect, feelings of numbness, strong feelings of guilt, depression, worry, or having difficulty recalling the traumatic event. Arousal and reactivity symptoms, for these, they usually require 2. Being easily startled, feeling tense, hypervigilant meaning you're quick to fight. You have a bit of trigger finger. Difficulty sleeping or outburst of anger. And cognition and mood symptoms, again, not everyone lists these in the criteria because they're similar to the avoidance symptoms, but we're going to list them just so you have all the information possible. Having difficulty recalling key features of the events, negative thoughts about oneself, one's loved ones, or the world in general, or distorted feelings like guilt, blame, shame that are out of proportion to the event, and loss of interest in things that were once enjoyable. Now, stress is a normal part of life. In fact, we couldn't live without stress. Our systems depend on some stress. It's a physical, mental, emotional construct that causes physical, mental, or emotional tension. Stress becomes a trauma when the lasting effects are perceived or are indeed life-threatening. Trauma happens when there's more activation of the nervous system than can be discharged at the time of the event. So the nervous system becomes overwhelmed. This can be cumulative, and this you'll see in child abuse, domestic violence, sexual abuse that goes on for years and years. Those kinds of traumas can be ongoing and have their own special kinds of problems. Trauma, it's important to remember that trauma lives in the nervous system, not the event. Yes, 9/11 was a horrific, awful, terrible event, but the trauma lives on in our nervous system. There is a saying that stress is to trauma, that sadness is to depression. So stress and trauma-related sadness and depression are related, but trauma is clearly a massive exacerbation of stress, and depression an exacerbation of sadness. Right after the traumatic event, some of these symptoms are to be expected, but if they continue again longer than 1 month and it's more than 4 to 6 weeks after, that's when you start considering it PTSD and not just post-traumatic stress. We also have to watch out for secondary trauma. Secondary trauma can happen to indirect witnesses of the event, volunteers, family members, first responders. Our profession, if you're treating a lot of people with trauma, you're definitely at risk for secondary trauma. And at the end of today's presentation, we'll go over some ways that you can help protect yourself. Secondary trauma is serious, but it's cumulative and it can take longer to notice. Trauma triggers are an experience that causes someone to recall the event. The trigger itself may not in and of itself be frightening. Let's say you are robbed by a guy in a red shirt. The being robbed elicits fear, which is normal. But if you had a red shirt on and you start to become fearful of red shirts, then the red shirt is a trigger. The red shirt in and of itself is not a scary thing, but it becomes connected to the trauma in your mind. A trauma trigger may or may not cause activation of PTSD. It's also important that you guys understand and I know some of you already work with PTSD patients, so some of this may be review, but it's very important information for those who have not worked with folks with PTSD or haven't done a lot of work. There's a difference between trauma activation and trauma discharge. We want there to be trauma discharge. Discharge allows the nervous system to go back to homeostasis so the person can start to live life in a normal way. Trauma activation is very difficult to live with. So some signs of trauma activations would be quick movements, rapid talking, or the opposite, vocal constriction. They may have an absent deer in headlights appearance, or flat affect, they call it, or they may have violent, angry behaviors. You may see an immobilization response, or you may see a hypervigilant response. These people will often have physical pain, dilated pupils, and difficulty identifying in the present moment. When there's a flashback, the nervous system basically doesn't know, it can't sort the person in their consciousness might know that it's not happening now, but the nervous system is overwhelmed with the past. In trauma discharge, all of which is helpful, you may also see quick body movements. So that is not enough to let you know whether it's activation or reactivation. You may see shaking. Shaking is actually really helpful for trauma discharge, and often it's particularly with medical trauma. If the patient's immobilized right away and isn't allowed to shake it off literally, that in and of itself can lead one at a higher risk for PTSD. You may see sweating, crying, laughing, sighing, vibrating, rapid eye movements. Those are all signs of trauma discharge.